Good morning, everyone. This is Deanna Mitchell with LeadingAge Michigan, and we're here again this week to talk about our response to the COVID-19 pandemic. Last week, during the conference call, I was actually thinking that the volume of directives, executive orders, and other information would start to die down. But unfortunately, that's really not the case, as I'm sure you all know. It's taken almost all of our time to review and consider all these directives, and we don't have to operationalize them. So I have to say that it's got to be a huge challenge for our members to deal with this public emergency, and especially in the context where we've had problems with staffing overall, this has got to be an additional challenge. So we certainly applaud your efforts every day to effectively serve our seniors, and particularly during this time. Because there's a lot of new information this morning, what we're going to do is we're going to present a few topics, and then we're going to pause. And we're going to pause for questions related to those topics. So I do encourage you to write questions in the chat or question box as they occur to you about those topics. But we want to kind of batch them together so that we're talking all about the same thing at the same time if possible. But please do submit your questions during those times. We will take some time at the end of this and put out a Q&A document that summarizes all of those questions and answers as we move forward. Additionally, Laura Funch will be on the call with me this morning, and we will unmute her shortly so that she can jump in and out as needed. Everybody else will be in mute mode so that we can make sure that everybody can hear okay. So moving ahead to the next slide, this is just a brief reminder that the Safe and Calm initiative is really intended to streamline member access to critical materials, help keep our members informed, especially about the spread of illness, and provide an avenue for questions and comments. So we hope that we're helping do this, provide the services for you in a helpful way. And if you have additional needs or things that we are not addressing as well as perhaps we should in your mind, please let us know. Please give us some feedback about what's helping and what's not. So next, our agenda this morning has not really changed from last week. We'll go through pretty much the same format every week. We'll talk about the national and Michigan current situation, our advocacy, and basically talk about the resources and the directives that have come out and what we might consider the important points about them. So let's go on to the national and Michigan current situation as it is right now. This slide is one now that I'm updating every day except for the weekends. And these national numbers identify the increases in confirmed and presumed cases as of yesterday's date. You'll continue to see that there's an exponential curve here. There is kind of a misleading gap here between the 20th and the 23rd because that was the weekend, and we don't always get updated numbers during the weekend. So that jump isn't quite as big as it looks, but you will see that there's this curve, and both nationally and in Michigan, we've just not yet peaked. The next slide is a CDC slide, and I showed it last week, and it kind of shows the density of cases across the states. And when I first looked at this, I was really kind of amazed because although the colors have changed a little bit, it looks pretty much the same as it did last week. And then I thought, well, how can that be? Because cases have grown everywhere. And then I realized they changed the legend. They changed the numbers for each of these colors, or Michigan would be dark brown now, along with a lot of other states. So even though the map looks similar to what it did last week, the cases continue to grow. The next slide is really, really interesting because it's very current, except Michigan is not on this slide for some reason. And it utilizes data through yesterday's date. And what this slide shows is the amount of time it takes state by state for deaths to double. And it's really a sign of the severity of illness in each state. And you'll see that Washington is improving. Washington, a state which had a huge crisis early in this outbreak, is now beginning to get their arms around and containing it, so that the amount of days, which is, I think, probably around, is beyond every week, where the number of deaths will double. New York, of course, is significantly challenged. They are doubling their number of deaths every 2 days, actually less than that. And I've heard that Louisiana, if you look down, Louisiana is challenged as well. So it's obvious that we have not hit the peak, although some states are doing better than others. And those tend to be the early states that experience the outbreak. So next slide are the Michigan cases. Again, it kind of has the same curve that you will see on the national cases, again with a break for the weekend. We are, as of yesterday, at 1,791. The next slide, I think, is really interesting. The next slide shows where the cases are really, really concentrated in Michigan. Wayne, Oakland, and Macomb counties account for 85% of all cases right now. Then the only other counties with double-digit numbers, as of yesterday's number, are listed there: Washtenaw, Genesee, Kent, Ingham, Ottawa, and Monroe. And if you look at this, you'll notice that these are where the big urban centers are. These are really where the outbreaks are occurring. You know, there's a lot of geographic density, population density in those areas. As we move forward, you'll see this moving out into the rural areas a little bit more. We do currently have at least one case, I think, in the upper at this point. So, and of course, 1,791 total. Moving on to LeadingAge Michigan advocacy, I want to just summarize some of the things that we have been in ongoing discussion with the legislators, the governor's office, and the state departments about. Because there's so much that's needed, we really have to focus our advocacy, and we've tried to do that for things that we think are most important to our members. The first one is, of course, the unavailability of personal protective equipment. That's really a huge issue. It's not only a state issue, it's a federal issue. The feds are trying to get more equipment and more tests to us. We think there are things that they could do to enhance that, and we have not seen that as of yet. We have noted that Michigan manufacturers are stepping up to the issue, though. I do know that the car makers are beginning to make supplies, but it will take a while to convert and make them available to do that. There are also some work with getting more sanitizer out, etc. So we are aware of pockets of initiatives, but we really think the state and the federal government could do more, and we continue to ask for that. We have not really gotten a good answer from the state about supplies. The second thing is the use of current beds. The use of current beds is really mostly about nursing homes. An executive order from a couple months ago has allowed LARA to remove the barriers to access licensed and other settings. such as assisted living, etc., when those beds become needed. The Department of Health and Human Services in Michigan is about to send out a memo shortly about using unavailable beds. It is noted that there's no expectation that providers will be able to go beyond their licensed bed numbers at this point. And I'll talk a little bit more about this proposed memo a little bit later. Another really important thing that we think that we haven't gotten a good answer about is waiving pre-employment requirements and specific position requirements, using people who are not necessarily trained as CNAs in some supportive roles, some flexibility in those assignments. We will talk a little bit more about that later as well, but we have not gotten a good answer about those things. So on to our next slide. We have continued to ask for a temporary wage pass-through to enhance our ability to pay nurse aides and other licensed staff to attract new hires and maintain some quality in our operations. We have asked the department, the Medical Services Administration, which administers Medicaid, a couple times about this. We've not gotten an answer about this at all. And it is true that there are funding issues and stress issues across all of it in terms of budget, but we believe that we're not going to be able to do a halfway decent job at all unless we get some relief in that respect. And last but not least, we keep asking to cease work toward the planned nursing home rate cuts that are associated with their new reimbursement system that's still scheduled for October 1. Now, we think the reality of this is questionable, because there's just no way that they can be prepared to do this for 10/1. But the current governor's budget recommendation still has a planned nursing home cut of, I think, 80 million plus gross funding, which would impact us to that degree, and only saves the state about $30 million a year. So we continue that message at all. So I do want to remind everyone that we're going to talk about the survey. We're going to talk about the what we're calling provider support and wellness surveys in a few minutes. And I know that that's a big issue for everybody. So I do understand that there are concerns about that. We'll talk about that later. What I'm going to ask you to do now, and I'm going to pause for just a minute, in terms of priority issues, are there any other than these, and other than your survey issues, that you think that we should be asking for the department? Just submit a couple ideas if you have any, and we'll pause for a minute or two to give you a chance to do that.
Additionally, Julia, just to answer your question, we will be distributing the presentation after the call. It will either come today or tomorrow would be my assumption. It will be the presentation as well as a recording of the whole webinar. So far, I have not seen any other questions come in so far, Deanna, other than that.
Okay, let's move on then.
Actually, I just did get one. I have been hearing that there is some unwritten direction on the use of volunteers. Is that accurate?
I am not aware of that. I think I will ask Laura to respond to that, but right now I want to focus on priority advocacy issues, and so let's get to that question a little bit later, and we will move to the next topic.
Sounds good.
So we'll move to resource updates. Well, before that, I'm sorry, using waivers as leverage. One of the things that we have done is we attempted to use what was going on in other states as leverage in our discussions with the Department of Health and Human Services and Laura, so that they can see that there are some options that they haven't taken on yet, because there is no state waiver for Michigan at this point. There's only the federal blanket waivers. CMS approved Florida's emergency Medicaid waiver request over a week ago, and since then they have approved 11 more. But there is a definite theme to these waivers. And in fact, the 5 things that's listed under Florida's here are the only things that are getting waived. So fast track provider enrollment. In other words, if you want to become a Medicaid provider, you can do it really quickly. There's not a lot of barriers. Medicaid pre-authorization requirements. That's mostly for things like getting into a hospital for an elective procedure, or even a non-emergency procedure, et cetera. There's Medicaid pre-authorization requirements for equipment, things like that. Some states are waiving that, waiving PASAR for 30 days. The ability to provide care in alternate settings, and to temporarily delay Medicaid hearings and decisions. But those are the only things that are being waived. And while these things are important, they are not the things that impact our members generally in their ability to care for people every day. So using those state waivers and what other states doing as leverage in our discussions hasn't worked so far. However, when we look at Pennsylvania didn't actually get a waiver, but they put out an executive order that changed some of the rules for nursing homes and other care settings. They're waiving their staffing minimum requirements. It's pretty low to begin with. They waived personal care home and AL staffing requirements because they have staffing requirements there we don't have. Providers must notify when staffing drops. And they did provide some flexibility for individuals to perform certain tasks with abbreviated focus training. It did not extend to functions covered under licensure, such as nurses, but they are the only state that has gotten away with some, and it isn't very pointed change, but they have provided some flexibility in training requirements for some roles. So they're the only state that I know that has done that, and they did it under an executive order. So I'm not sure why Michigan couldn't do that. We're going to continue to put that issue in front of the departments as we move forward. So moving on to resources. A lot has happened since the last webinar on the 18th. The Family First Coronavirus Response Act was finalized and signed and put into law. It is effective about 15 days after being signed, which we anticipate will be about April 2nd. There are 2 acts within this overall act that will apply to our members. One is the Emergency Paid Sick Leave Act, and the other is the Emergency Family and Medical Leave Expansion Act. So the overall bill provides for credits against the employer's payroll taxes that will be equal to 100% of what you're paying out in terms of family leave wages and paid sick leave wages. I'll be honest with you, I'm not sure exactly how that's going to all work out. I'm not an HR employer payroll tax person, but there will be information and details coming from the Department of Treasury for that piece. And you'll also see more details from the Department of Labor about the changed rules for both of these areas. So the next slide tells us about the Emergency Paid Sick Leave Act. And this act provides paid sick leave for persons who cannot work for any of these reasons listed here. and the act is extended through December 31st of this year. So if a person is subject to quarantine or isolation because of COVID-19, whether they have it or not, if they're subject to quarantine, or they're advised by someone to self-quarantine, such as if they're a very high-risk individual, or experiencing symptoms but they don't have a diagnosis yet, and someone who is caring for people who are quarantined, children, for school closures, etc., paid sick leave can now be paid to persons because of any of those criteria. In terms of covered employers, employers under 500 employees must comply. But if you have under 50 employees, you can ask for an exemption. How you get an exemption isn't clear yet. Again, we can expect those details from the Department of Labor. Employers, and this is a tricky portion of the current FLMA law. Employers can exclude from coverage healthcare provider employees. So that's what it says in the law. But currently, that limitation applies to MDs, nurse practitioners, midwives, and clinical social workers. So it doesn't necessarily apply to other healthcare workers, but I'm sure that you will get a better understanding of that with this new explanations that we can hope for from the Department of Labor. In terms of the employee eligibility, employees are immediately eligible for this paid sick leave. There's no waiting period after hire. Full-time employees are entitled to 80 hours, and it's prorated for part-time people. The sick leave cannot be carried over past the due date, and it's not available to be paid out. It's obviously just meant to help people get through this temporary issue, public emergency. There are pay maximums here, and up to 2/3 of pay, up to $2,000, is available if you're caring for somebody else. If you are required to be at home to care for someone else who might be ill related to the virus. Then we move on to the other portion that applies to our members, which is the Emergency Family and Medical Leave Expansion Act. There is a requirement here that people have to be employed for at least 30 days. And the expansion of the medical leave rules is really intended to include need of caring for children under 18 if school or their daycare, et cetera, has been closed and childcare is unavailable. Those with fewer than 500 employees, again, are covered. And basically, in terms of excluded employees and exemptions for small business are the same as for the paid sick leave portion. So moving on, the first 10 days of this leave has to be unpaid. The employee can substitute any unused paid leave time in lieu of, unused paid leave time in lieu of unpaid leave first to cover that 10 days. And again, the pay rate is about 2/3 of their current pay, not to exceed $200 a day. And the availability of time, which is 12 weeks for any FMLA, I think it's FLMA issues, still applies here as well. So any questions about either of these two acts? We don't have a lot of detail about much more than what was presented. We anticipate more coming from those two departments, but we'll pause here to see if there are any other questions.
Is the 2-week sick leave in addition to existing sick leave benefits the company may already offer?
Wow, that's a good question. I don't know the answer to that. We'll have to research that. I do want to remind everyone that we have a couple events coming up that will go into detail about these two acts as we move forward. I would think that they would have to use all of their current sick time first, but I don't have any directive or explanation stating that. And again, I would think that it would be in addition to current sick time levels because people get sick through the year. So if it's needed, I do think it is meant to be added on. But again, that's not explicit anywhere, and I would wait for guidance from the Department of Labor.
All right. And then another one that I don't know if it necessarily fits into this category, but they said, is there any discussion about reevaluating quality measures? We will likely see an increase in antidepressant usage and potentially functional decline since residents spend more time in their rooms.
I don't believe so. I've not heard of anything. I don't know that I've not heard the CMS is considering anything like that. I think it's a good point though, and I will float that up to LeadingAge at a national level, and we'll put that on our discussion list with the department.
All right, and then as Deanna said, we do have a couple upcoming webinars. Finance and Strategy Day next Tuesday, as well as our SNF Regulatory Day, which will be Thursday, April 9th. And some of these questions might be answered there as more information comes out. So far, I do not see any additional questions other than that, though, Deanna.
Okay, let's move on. So what I've done here for this slide is I pulled out the resources that have been we've posted for during the last week that really apply to all providers, not just nursing homes. I do know that other settings such as independent living, affordable assisted living settings, home and community-based services kind of get lost in the shuffle of the huge number of directives that come out for nursing homes. So we pulled out these pieces that are particularly applicable to everyone. We would encourage assisted living and AFC and housing providers to review screening tools and safety practices that are also required in nursing homes, especially for residential settings. The screening criteria is appropriate for assisted living, and I think that you can gain a lot of best practices by reviewing those. Additionally, there's a CDC update here for retirement communities and independent living and business employers as well. A lot of information here for everyone. What we will do is when we put out this PowerPoint for review, we'll make sure that all these links work for you. And if you're looking for non-nursing home updates on how to deal with the virus and the viral outbreak, you would have that at your fingertips. So the next slide I have kind of just copied from our last week because I wanted to clarify a piece. These are the two federal blanket waivers to date. The one that waives the 3-day prior hospitalization for SNF, we've had a lot of questions about that because the way it's written, it does appear that it could only apply to persons who are evacuated, transferred, or dislocated as a result of the effect of disaster or emergency. So it could be people who might have COVID or have been moved because other people have COVID. But that's not what CMS followed up with. CMS, in a discussion with LeadingAge, followed up with the fact that this is really meant to apply to absolutely everyone in a SNF. So there should be a waiver of the 3-day requirement for everyone, just to make that clear as we move forward. So slide 24, next slide. This is the infamous piece that we expected for a long time from CMS. This QSL letter, we would hope would give us some survey relief. I'm really kind of surprised it doesn't really feel all that flexible. I do think that reading through it, everyone's pretty clear at this point that surveys will be focused on potential IJ complaints and targeted infection control surveys. And there's no question in my mind that they are really going to look at these infection control surveys. They are going to suspend enforcement remedies for everything except immediate jeopardy, and they're going to terminate all survey visits at this point. It's important to remember, though, that they plan to follow up on anything that might have occurred during a survey that they're going to suspend for now. They're going to follow up on any issues that they get complaints about that don't look like they rise to the level. So I don't want everyone to get really complacent and think, well, the surveys, regular survey stuff is over and we don't have to worry about any of that stuff. That's not the case. They are going to continue to log complaints, enter complaints into their electronic system, and I would venture to say they're going to follow up on any survey issues that might be up in the air during this time. So remember that all other issues are going to be followed up later. Also, there was a very direct statement in the middle of this that surveyors must meet the expectations for personal protective equipment according to the current guidance, or they won't be able to enter a facility. So that's another new piece. So there are the infection surveys, and it's unclear whether or not these surveys are random. It was not clear to me, at least. But we think that they might be based on the provider support and wellness contacts that we're going to talk about in a minute. There does lack some clarity about use of a self-assessment tool. They say it's optional, but you may have to submit it during an infection control survey. Well, that's not clear. I would consider it not optional. I would consider it required. I think it's possible that they can't mandate that you do it in advance, but they could certainly ask you to provide one during the survey, and then you'll be scrambling. So I would strongly suggest everyone consider the self-assessment tool to be mandatory. So some areas of thought as we reviewed the screening tool, and one of the things that we put out yesterday is we pulled out the elements of the nursing home screening tool in one discrete document, just to use internally, that was a little bit easier to negotiate. It has all the exact same elements in it. It just is pulled out from that larger tool that was created for a whole lot of different providers. So anyway, things to consider when you're going through the screening tool. These are areas that have been cited and are areas of concern as we move forward. You need to make sure that your surveillance process is a real surveillance process. A lot of facilities simply write down where their infections are, and little or no analysis might come through that. And I think in particular for this viral outbreak, it would be very important to track where respiratory symptoms are occurring in your facility. I do know that a lot of facilities don't really track geographic locations of infections, but I think that that's critical. And as we move forward, you should have a process. It should be in your policy, and you should be prepared to talk about this to a surveyor. Another thing is, what actions have been taken to obtain necessary supplies if there is a shortage? What is your plan to work around that? And does your staff know all of that? In other words, if you are going to substitute one kind of supply for another, if you have a reuse or a priority plan for certain kinds of supplies, all of that needs to be in your policy, and your staff is going to be asked about what those policies are if you're having shortages, and they're going to be expected to know it. So that's another important piece. As with any survey, the staff are going to be expected to be aware of the individual status of each of the patients that they care for and what their level of contact or their precautions might be. So that's an important piece. Make sure that your staff are ready to respond to those questions. Cleaning protocols for reusable equipment. We do know that a lot of people get cited for cleaning glucometers, etc. I would want to make sure that that is absolutely critical if you're reusing equipment between people, especially anybody who has a respiratory symptom. So I would make sure that those protocols are well known and being followed. One of the things that happened and that is highlighted in the directive from CMS is that you need to pay attention to your emergency staffing plan. Apparently, there was a medical director who became ill. I actually think he eventually died in one of the Washington facilities, and there was no backup plan to cover for him. So make sure that if your essential staff become available, that you have a plan not only for the number of nurse aides you have or the number of nurses you have, but other essential people. That is a requirement of most emergency preparedness plans. I don't know if a lot of facilities have gone into that detail. Overall environmental cleaning, make sure that your environmental cleaning actually does include EPA-supported disinfectants, and especially things that are appropriate for COVID-19. Last but not least, there's a lot of confusion about screening for travel. And I don't know if members are feeling that or if it's just at higher levels. But the original screening directives and the current screening directives from CMS all say that people who have traveled recently, people who have come from highly contagious areas where there's community spread should be screened. However, CMS, in some of its communications, but not directives, has said that that's really kind of moot anymore because pretty much you can depend that there's community spread everywhere. It doesn't matter if they've traveled. If you're just in Wayne County right now, you should be considered at a certain level of risk, and you can't really stop anyone. There's no difference, in other words, between someone who's traveled and someone who has not. Unless you're coming from China or something. So the directives, though, have not stopped that. There's no directive that says you should no longer screen for travel. So we're going to suggest that you go ahead and screen for travel, but know that everyone who's traveled is not necessarily going to be quarantined, because the person down the street at this point who hasn't traveled is likely to have COVID-19 as much as people who've traveled. Okay, so moving on. This is the part in the last 24 hours that has caused me a lot of concern, and I'm sure it's causing a lot of our staff concern. I did see in the last hour or so that we've gotten some emails that about this. For this slide here, I pretty much have only copied most of what actually was sent out from the department early last night. These are the wellness checks that will be conducted for your facility. You do have to provide your survey team's manager with the name of a contact and email, and then you'll be getting a phone call. So when we met, well, we had a conference call with the department about a week or two ago already about this issue. They did try to assure us that these were not going to be punitive things, that they were really just reaching out and trying to help. And I really did feel that that's what they were thinking at the time. But then when I got the questions yesterday, I thought, oh my word. Moving on to the next slide, somebody in our office just said a little while ago, this is like going to confession. Do you have enough staff? These are judgments that are not easily discussed, and I would be very, very careful. I mean, everyone's going to have to do this. We will go ahead and have some discussions with the department about what we think about this tool, but I certainly wouldn't respond with all of my thoughts about whether or not there are significant operational concerns you want to share with the state. That just undid me. So my personal feeling is what I would do is I would stick to facts. Do you have enough staff? I would tell them what staffing ratios I have right now in terms of licensed staff and non-licensed staff. I would tell them if there are PPE issues, I would certainly tell them that. Essential supply issues, I would stick to facts because these are so general and could be so subjective that I would just be very careful what I did. And of course, you're going to have to answer yes to, did you implement restrictions? It's possible, again, as I said before, I'm not sure if they're going to focus those infection control surveys based only on a random plan, but I do know that they plan to make visits if indeed the answers to these questions are not what they want to hear. So I again can only suggest that you be very careful, very factual with what you put on this page. Next slide.
Deanna, may I add in here?
Yes. Go ahead, Laura.
Oh, thank you. I didn't hear you. So yeah, I would agree with you, but I also think that I believe that not only based upon that information coming from the facility, which I would highly recommend, you know, depending upon the time of the day or the person that's calling or the survey manager that's calling the facility, that when that call comes in, wherever it comes in, that whoever answers the phone directs it to the administrator in charge or the DOA in charge, who's ever in charge. Said in another way, for it not to be answered by a charge nurse or somebody that may not know the bigger picture of the operations in that facility. So that'd be my first thing that I would just offer up. The other thing is that I too believe that information in terms of these infection control surveys going forward is not just going to be gleaned out of these wellness checks. I believe that information that's being reported to the local public health departments and for like confirmed cases or whatnot, depending upon that information is also getting fed back, obviously, to the state agency and the regional offices and whatnot. And that information in itself may, you know, bring forward an unannounced infection control focus survey. So I believe there's going to be multiple areas where information is being fed to, for lack of a better word, the hires up, where if there's reason for concern, that's going to trigger a survey.
Right. I do want to remind everyone that the actual provider wellness check is, I believe, going to be a written thing, and that they will use the email of the contact person to forward that to you, because you're going to have to do this back in writing. They did talk about some calls as well. If you don't respond, they're definitely going to call. I think it is a good idea, as Laura said, to make sure that your staff are aware that if someone calls, that those calls are focused or sent to the appropriate party. Any questions about this or any of the other things that we've talked about to date before we move forward?
All right, I have a few that we have not gone through so far. The first was, did the third Congressional COVID-19 Act include an exclusion for not-for-profit providers said on LeadingAge yesterday?
I'm sorry, can you repeat that? I didn't get it.
It says, did the third Congressional COVID-19 Act include an exclusion for not-for-profit providers said on LeadingAge yesterday?
I believe you're talking about
providers.
Yeah, that was what I was assuming. Not-for-profit providers would be my assumption.
I believe that there is some language about that. I would have to research that in more detail. I do believe that is the case to date. I would have to look at that more, and we can do that.
All right. Is it clear what the effective date of the DPNA relief is? Can we assume it's all pending DPNAs regardless of effective date?
My understanding is that,
I
yes.
believe that affects.
Go ahead, Laura.
No, you're right. I was just, the effective date, I believe it was March 20th. So anything that was in the queue on March 20th would be suspended.
Remember that that only applies to per diem. Anything that might have been a mandatory per instance DPNA would continue, and any mandatory DPNAs related to IJs would continue, but the others should have already been suspended.
All right, this one's more of a statement. They just said we have already received a call from our assigned surveyor asking for the completed form that we just received. Right.
I anticipate that that those are going to be coming out fast and furious at this point.
All right. Regarding PPE, is every home utilizing the regional EMR input to make sure our state gets what we need?
I would certainly hope so. I don't know of that. I think that letting everyone know what your supply issues are through your local health systems is critical.
All right, and then just an additional comment from the previous one about the surveyor asking for the completed form. She said they seemed anxious for us to return the form as soon as possible.
I'm sure of that. I think that this and their infection control piece is going to be their primary purpose in life in the next several weeks, and I think there is a definite message from CMS to ensure that nursing facilities are maintaining infection control because of not only, mostly because of the number of vulnerable people that we have in our communities.
All right, another one that's kind of more of just a comment. They said, I know one of our facilities has a standing weekly call with the surveyor. She asked us for a standing day and time. Not sure if all are doing this.
Huh, wow. That's the first I've heard of that. That's an interesting point. We'll monitor for that.
Should facilities be holding mail or packages from residents for a certain amount of hours before distributing?
Can you repeat that?
Oh, wow.
I got the first part, but not the second. And I'll let you respond to it, Laura.
No, so I was just thinking out loud, for holding mail for a certain amount of time before you give to the resident. And I'm sure that's because of the virus being viable for X amount of time on a document or whatnot. Wow. I guess another, I mean, yeah, how do you?
I have heard that.
I suppose somebody.
I have heard that postal workers are screening daily. I don't have that in writing somewhere, but I do know some postal workers, and they tell me they're screening every morning. So, although that doesn't necessarily prevent anything, I don't know. And Laura, I will ask your opinion about what your take is on that. But I think that holding mail isn't probably going to help a whole lot. What's your opinion, Laura?
No, I would agree. I mean, since the resident is not allowed too much visitors and whatnot, so I'm trying to think outside the box. How could you manage delivering that mail to that resident while maintaining an infection control issues or practices? Is it possible that when the mail comes in, that somebody excuse me very much, deliver the mail to the resident with gloved hands, ask for permission to open it up, and then maybe dispose of the envelope, or the immediate heck, I don't even know if that virus would go through a piece of paper. I would be concerned on holding residents' mail. I mean, that's going to be a social thing that they need, but I'm going to research that to see how long that actually would if it even penetrates paper. I don't know that answer, but I will research that today.
Okay, and we will get that into our Q&A. Anything else about issues that we've discussed so far, Blake?
Yes. A person from a separate facility said we also have had surveyors set up a time for a weekly phone call as well. So it sounds like it's happening at multiple places at this point.
Okay. All right. Well, seems to be a scheduled thing then.
Have you any information on the activities of the SEIU? Are the same actions from Wayne and Detroit happening elsewhere, making demands, etc.?
To date, I have only personally been aware of SEIU activity in the Detroit area. We did receive a copy of an agreement that they wanted our facilities to sign. Our only response to that today has been to have our members obviously consider whether or not they really need to sign that agreement, and to consult their attorneys about it. So I would be careful. I would just be careful. But I only know of what's going on in the Detroit area is all that we've heard about, at least me personally.
All right. The CDC is now recommending all long-term care healthcare providers wear a mask, whether or not residents are ill. Are providers doing this? We are concerned about depleting supplies before we really need the mask.
My understanding is that if you are in an area of community spread, community transmission, which at least in our big counties that I highlighted earlier yes, the directive says that you should do that. However, you also have to figure out that if you don't have supplies, and if you anticipate that you're going to run out of supplies, you have the ability to figure out how, for your facility, how best to conserve those supplies. You need to put that in your policy. So I think that you could identify high-risk persons, or you could identify people with respiratory ailments. You could identify certain units where patients are more vulnerable. You can use that, the ability to conserve your PPE in that way. You just have to do it in a very structured way, and you have to write it in your policy and make sure that all of your staff know it. That would be a decision to be made by an individual facility.
All right. What guidelines are everyone following for end-of-life visits?
Well, I would like to hear from a lot of members about this, but that is another thing that facilities have been interpreting, and I think appropriately, on their own based on what they feel the need is. Some most I think are actually only allowing visits for people who are actually actively close to death. And I would think it depends. If you have a facility with a lot of hospice patients on it, but they have not really moved that quickly toward death, you could have 10 or 20 people visiting again, and that would be not really the intent of the sheltering in place guidelines. If you have someone close to death, obviously you should be allowing those visitors in. But again, I think that every facility has to look at their own population, what their own population needs are, and figure out how to interpret that. It was not clear in any of the directives, either from CMS or the executive orders, what end of life meant. But I personally would interpret it as being closer to death.
All right. Can you define widespread community transmission?
I do think that there's some parameters out there, but I don't know them off the top of my head, but I can tell you that pretty much Michigan is considered, at least the lower half of the lower peninsula is all considered widespread at this point. I know Wayne, Oakland, Macomb, Kent, Ingham, and Genesee all have widespread transmission.
All right. Are wellness checks also being done for AFC and HFA licensed facilities or just SNFs?
They are being done for all licensed facilities. If you go back to our call summary from, I think, earlier, maybe Monday or Friday of this week, we did notify everyone that these wellness visits are going to be conducted for every type of long-term provider, actually long and short-term. Any kind of provider that's licensed by the state of Michigan is going to get a wellness visit or some sort of check of some sort.
And then Missy Latter did confirm, she said, yes, Michigan is widespread per the CDC.
Right.
Other than that, I don't see any other questions. Again, just a reminder to everyone, we do have some education coming up that will be covering some of these topics, like SEIU will be discussed during the upcoming Finance and Strategy webinar, which will be on Tuesday, March 31st. And you can go ahead and register for that on the LeadingAge Michigan website at leadingagemi.org. We also have the SNF Regulatory Day coming up April 9th, 2020, and that will be a webinar as well talking about some of these topics.
Okay, moving on. We have a few more updates to discuss before we close for today. I do want to go into use of nursing home beds. As I said earlier, the department is working on a provider directive letter that will allow for flexibility for use of beds. Basically, what they're talking about so far is the ability to simply move Medicaid and Medicare patients throughout your facility, no matter whether or not those beds are certified in any special way. They will allow facilities to put non-available beds back into service. You wouldn't have to request anything, but you might have to notify the department. Remember, though, that these are all in process. We've not gotten a final determination, so none of these are applicable today. There is some discussion about converting double rooms to single rooms for Medicaid patients in case that person might have some respiratory symptoms, but isn't necessarily in isolation. Maybe in order to increase your capacity to make a large single room into a double room if needed. The ability to cohort people with respiratory symptoms and or COVID in distinct parts of your facility without regard to which beds are certified where. But I do want to make sure that there is no intention on the part of the department to increase your number of current licensed beds. So we are looking for this memo. I think it's going to be delayed a bit because there were a lot of cost reporting questions involved in how all of this would work. And I think that they're working through that. But this letter should be coming out, I would hope, in the next week or two at least. Next slide, Blake. I put this in here just to remind everyone, this is the slide from last week, the Governor's Executive Order 2020-13. Just to make sure that everyone's aware that while we thought that they were going to lighten the basic requirements for certified nurse aides, in essence, all they have is changed the examination requirements. And the department is talking about how they would issue a temporary registration for people who could be working as a nurse aide and haven't taken the exam, but I have not seen that yet. So I just wanted to reaffirm with everyone that we still are living under almost all the same rules as before. And then the next piece is about the order to shelter in place. That's a rather long executive order that was, I think, from Monday. This 2020-21, these are just the major highlights that were kind of called out to me as we reviewed it. Remember that you have to determine which employees are considered essential, and you have to inform them of that. You have to make such declarations in writing to them and have a document that says in your policies which are essential. Those declarations can be made orally until March 31st, but after that date, you have to have it all in writing. One of the things that jumped out at a lot of people, including me, in the order is that is about adopting policies to prevent workers from entering the premises if they display respiratory symptoms or have had contact with a person who is known or suspected to have COVID-19. Obviously, contact is critical. But I think that everyone needs to look at the intention of this policy. It's not to take someone like me who has some respiratory symptoms all the time and not allow them to work on the premise or access the premises. I really think it's for people who have new or increased respiratory symptoms, and I think you have to look at the intent. If I have allergies all the time, which I do, I always have a little bit of a cough, especially looking at whether or not someone has a temperature, if they've increased their respiratory symptoms. So I think that you should all put in your policies some way to separate people with chronic respiratory issues. Some people have COPD. They always have respiratory symptoms. And how to utilize those people as best and is appropriate while still screening for COVID-19. Or you could lose half your staff here, especially in the spring when allergies are going crazy. So I think that facilities should think about this critically and try to address it from a little bit different standpoint than just preventing anyone with any respiratory symptoms at any time from entering the facility. Making sure that everyone maintains a 6-foot social distancing when possible, and making sure that facility cleaning and disinfection is up to EPA standards to prevent contamination with COVID-19. Those are the 4 things that jumped out at me, but especially the issue about respiratory symptoms. And then moving on We want to remind everyone that we have a specific email address for member questions and comments. That's safeandcalm@leadingagemichigan.org. We do want to hear what you're struggling with. We want to hear how you're doing out there and what your concerns are, what your questions are. So please feel free to do that. Also use our listservs. Our listservs give everyone the availability of talking to each other and not just the staff here, and identifying what some of you all are doing. The other thing is I want to remind everyone that the compliance store is allowing assisted living providers complimentary access until May. And they also provide discounted rates for nursing homes during that same period. So if you need some policy and procedure support, they are really good at that. And ALs who are not quite used to all of these issues may do well to access that. So we're going to pause one last time for questions before we call it a day. Any last questions? If you submit a question, we don't get to it, we will go ahead and make sure that it's in the Q&A that comes out later.
All right. Does it concern anyone that CDC facility policy now says it's okay to use a face mask for a whole shift, putting both staff and residents at potential risk just because of lack of supply?
Well, I wouldn't say that it concerns me personally. You know, I will ask Laura to jump in here in a minute. I think that considering everything, everybody just has to do the best that they can. We will continue to fight for more protective personal equipment as best we can. But I think that considering the shortages, you're going to just, there are going to have to be some changes to the hard rules of infection control as we move forward. Laura, what are your thoughts?
Thank you, Deanna. I would agree with you, and I would also add that, you know, depending upon the resident that you're serving or the scenario that you're in, using that same mask definitely wouldn't be appropriate. So, you know, on a day-to-day, case-by-case scenario, you may say, no, I can't do that for this. Do the same mask because it doesn't fit this resident's need. So, I agree with you, Deanna, and I think it takes a common sense approach to the employee in that given shift on that given day and the residents that they're serving to use, you know, a common sense approach in terms of appropriate infection control practices. It is concerning. That's what I have to say, Deanna. Thank you.
All right. And then I just have one last question. It looks like CMS guidance says if they are asymptomatic, even with known exposure, they can work with a mask. So I guess maybe not a question, maybe more of a statement.
Right, right.
Oh,
okay.
No, there was a question. There was a question right before that, and it said, "Doesn't the latest CMS guidance for healthcare workers say if they are asymptomatic, even if exposed to a positive person, they can work?" So, and then that was the follow-up from it.
Right. We will go ahead and we will put all of these questions and maybe a few that we get on our listserv / dedicated email. Our dedicated email as we move forward, and we will get that out hopefully later today or early tomorrow. I want to thank everyone for attending today, and please keep your questions and issues coming. We want to continue to try and help as best we can. Again, thank you everyone, and we will talk with you next week. And please visit our website daily. We have daily updates coming up. Thanks.